Here we go. Welcome, welcome. Good morning, and happy Wednesday to one and all. Crikey, we've got some numbers today. As you join in, if you could just drop a 1 in the chat and let me know that everything's working as it should, that would be super helpful. Thank you. 1 from Jonathan Scott, first to the bat. Wow, look at that. I mean, you should all know this is coming. You should be prepped and ready, hovering over the 1 key. Racing towards Easter. Is anyone feeling the Easter vibes yet? Well, I'm hoping so, because I'm hoping you've swung by our academy and have possibly discovered an egg hanging around in one of the academy courses. I'd love to know if you have, so if you could just drop a 2 in the chat whilst I'm distracted admitting people, that would be super helpful as well. If you don't know what I'm talking about, don't you worry. I'll get to it in a minute. Crikey, Marikey, this is flying off the handle this morning. I'm excited. 45 people and counting. Any 2s yet, Max? Have we had any 2s? No 2s, so nobody knows what I'm talking about. All right, well, here we go. I'm going to put a link in the chat. Don't look at it now, look at it after the webinar. But if you haven't seen, or if you don't know what I'm talking about with regards to eggs in academies and the such, please swing by after the webinar and take a look. If you've been paying attention to other things that are happening across healthcare, and I don't mean the headlines, I mean events, you'll know that event season is in full swing. So my icebreaker for you this morning is, what is that one event that you can't possibly miss during the healthcare event season, just because of FOMO more than anything else? Is it the big ones? Is it the best practices? Is it the rewireds? Or is it perhaps the smaller ones, the management in practice or pulse PCNs? What was that one? Goodness me, Jang. Well, that was an unexpected turn of events. Well, I'm very sorry to hear that. I actually went to one on Monday, so there we go. Best practice. Thank you, Charlotte. Any others? Anyone go along to Rewired last week? I know Max was there. Living it large. Anyone else? I mean, don't leave me hanging. If the answer is, of course, you don't go to any events, you can't be bothered, then pop a 0 in the chat. That'd also be helpful to know. Don't leave me hanging. Wow, Cheryl. Okay, fair. No time, sadly, Sarah. Do you know what? I feel your pain. Always amazed that people have time for events. Yeah, you know what? Absolutely. Anything close to where we are. Where are you? Dom, I'd love to know. All right, well, we'll keep that chat going. But yeah, I'd love to know which of the events that are important to you, which ones you don't attend. Jang, come on. You're invited wherever we go. Absolutely. So please, we'd love to see you there. Right, we've got record-breaking numbers with us today, which is why I am absolutely flying off the handle with buttons left, right, and centre, which is super exciting and entirely nerve-wracking. So bear with us. For a little bit of housekeeping before we get going, as always, just to let you know that the call is going to be recorded for prosperity and sharing. If you need to drop off at any point, don't hesitate. We will share the recording with you. Also to say, we're going to try and keep it to 30 minutes. Those that are regulars will know I'm absolutely useless at that. And I've got Max with me today, who's equally as useless, but we will do our best because we know that you are all very busy people who don't have time for events. So second of all, we love the questions, so please keep them flying in on the chat. I will get to them as soon as we can, but whenever you feel the urge, please do feel free to pop a question in the chat. And as I've alluded to, we've got Max with us today, who really likes the tough questions, so please feel free to test him. I'm here for it. Right, my name's Lucy Glynn, Community Manager here at Exxon Health, and I am absolutely thrilled to have with me today the man, the myth, the legend, Mr. Max Gattlin, back in the hot seat and on presenter duty. We've got some exciting topics today, haven't we, Max?
Yes, we do, Lucy. Morning, everybody.
Good morning, good morning. Right, are you feeling a little bit apprehensive about the amount of people we've got on this call?
I can see the numbers ticking up. It gives me more excitement than anything.
Oh, good. All right, it's just me then. Well, without further ado, Max, I mean, this topic is a big one for you, isn't it? You've got some big thoughts and feelings on it. I know it's a bit of a personal mission for you. So I'm excited to see what you're going to talk to us about today. Over to you. I'm desperate to get past this front slide.
Fantastic. Thank you. Yeah, good morning, everybody. Again, in the essence of time, as Lucy's alluded to, we tend not to leave much time for questions, but I'm really keen to leave at least 5 minutes at the end for questions. So without further ado, we'll dive in to The agenda of today, so first we'll look at access, consider our current challenges in the market, and I don't want to teach anybody to suck eggs, but I just want to show, to set the context of the next 25 minutes or so, why we believe delivering such a model is so important to not only achieve national agendas, but also locally. It's really important, and as Lucy said, it's a passion project for me, so the more people that join and listen and share, the merrier. We'll also look at a demo of a product that we slot into this model that supports. We'll look at a bit of data about how we move from reactive to proactive care, and then hopefully, we'll have 5 or 6 minutes for questions at the end. So the first thing I wanted to let us know, and I did present this at Best Practice Show, so Lucy, it was interesting to see how many of our viewers are at Best Practice Show. I think there were a couple, but not too many, and I don't want to be seen as repeating myself. But one thing I just wanted to focus on was the national context, so our current challenges and the impact on not only our primary care teams, but more so the health of the nation, and of course the system that we're all a big part of. So as we have increased demand, we've got, well, due to multiple factors of aging and growing populations, dwindling workforces in a certain sense, and that's causing a lack of access for patients to access services, whether they're general practice services, community services. There's a lack of access or a delay in accessing those. If we can't access those services, of course, we have delayed care. We've got the nationally known target of getting an appointment with your GP within 2 weeks, or at least being seen within 2 weeks. We've got that metric. Anybody that sat on a meeting with me and we've looked at the Surgery Insights dashboard, you'll know that I always highlight that page. It's our appointments tab on that dashboard. Yes, we've got 8 other tabs that we have on there around digital access, digital adoption, digital usage. So yes, patients may have the NHS app, but how many prescriptions are being ordered through that? Online consultation submissions, what's your rate per 1,000 patients of online consultation submissions, and so on. But the most important part for me, the reason that we want to improve all that access and monitor those metrics, are to ensure that our patients are being seen in a timely manner. Because if they're not, then we get an increased hospital admissions. So we've got, again, there's a big focus now on long-term condition management and preventative care. We need that because at the moment we've got too many citizens, patients being admitted to hospital. And of course, that has multiple factors, including economic strain and pressure on the system. When we've got pressure on the system, we have less time. We're all working too hard trying to stay afloat, and we're not focusing, or we don't have time to focus on that preventative care, which just compounds the problem. And I just wanted to bring this slide up front to say this is the national context, and this is why it matters. And I know there's a big focus on access in primary care, but it has a knock-on effect to the wider system, and again, the health of the nation. Just to put some numbers around that in terms of access to primary care and the thoughts and feelings of our patients, so taken from the Ipsos GP patient survey, we know that half of patients find it difficulty getting through by phone. I sit on probably 30 hours of meetings a week with general practice and primary care network, and it varies, size of surgeries, phone systems they have, what they're using, it does vary. But on the whole, across the nation, half of our patients find it difficult getting through by the phone. It's still an issue with websites. Patients are having difficulty navigating websites, finding the right information. We've got to remember, patients don't know their solution. They don't know the name of the service. They might think they'd still need to see a GP. All they know is their problem. And it's really difficult, the way that we've constructed some of our websites, in how to effectively navigate patients elsewhere. And we'll go on to placement of certain banners, etc., as part of this model, because there's a bit of a slam dunk about 15 minutes in that I'm going to share with everybody. And again, there's been some amazing work on the NHS app. It's if not the best product in healthcare at the moment. Every patient needs to be on it. I was part of a fantastic talk at Rewired, so thanks for giving. I know that not many people here have the time to go to these events because they're caring for patients, and the whole reason we're here. But in order for us to improve our access and services to help you better, I need to go and do the research and understand what's happening in the market to make sure we can best support our patients and our primary care teams. So I did attend Rewired, lucky enough to attend both days. And on day one, I saw Rachel Hope, so Director of Prevention at NHS England, and Professor Joe Harrison, CEO of Milton Keynes University Hospital, did what I think was the best talk across the 2 days. It was a 45-minute session on the NHS app and what is coming. and it's evident we need to get every patient using the NHS app, but we need to do it in a cost-effective way. We don't want to be sending tens of thousands of text messages out to patients to download the app. We don't want to be putting our practice staff in the waiting room to show a patient how to download it or order their meds. So we'll part of this model, we're going to focus on how we can improve all of these modes of access, but do it in a cost-efficient and time-efficient manner. Do let me know if there's any questions that pop up, Lucy. I've really just scene setting at the moment, but hopefully this is ringing true for everybody in the audience. So I wanted to spend a little bit of time on this, just because I know that it's been bounded around, this move, these three kind of key pillars of our direction of travel. So moving from hospital to community, this is really about enhancing community-based services. As I said before, we need patients to receive timely interventions in familiar settings. At the minute, because demand is outstripping capacity, if you look at the data of the demand that's flowing into general practice, we could say that 30–40% of that is being redirected back out of general practice. So as part of this operational efficiency model that I'll share with you in a couple of slides' time, we want to reduce that by automatically signposting patients away rather than flowing that demand through general practice. It's not just community, so local authorities, community organisations, lots of local charities, national charities that we can work with to help streamline that pathway for the patients. The move from analog to digital, again, we've done a fantastic job over the last, I'd say, 4 to 5 years. The DFOC-VC framework, digital pathways, there's lots of different products and lots of funding that's come down for those products. We've spent lots of time and money on configuring them, integrating with our clinical systems. But again, how do we effectively, rather than manage all of that demand that's coming through that front door, how do we effectively signpost it or navigate it away? But moving from analog to digital is part of that journey. So utilising online triage and consultations, offering virtual consultations. There's some fantastic products out there that will allow you to do this. Again, adoption of digital tools. I couldn't scream it any louder from the rooftops. I know we've got different types of patients, demographics, different socioeconomic backgrounds, levels of deprivation. We're looking at all of that, and we take that into account in every partner that we work with, or every practice that we work with, to make sure that nobody gets left behind. And this model isn't just, and I will say it, it's not just for current Exxon Health customers that are using the Surgery Connect phone system. This is for every practice in the country, because it's really important we don't leave anybody behind. So the data on the previous slide, that was a national picture from every surgery or every patient in the country. So it's really important that we impact every practice. So it doesn't matter if we call it a digital infrastructure. It doesn't matter which online consultation tool you use, which phone system you're using, which website provider you use. This model can be applied to your surgery. I just want to make that abundantly clear there. So sickness to prevention, this is probably the biggest one for me. So going back to that 5-step graphic that I showed on the third slide, it's all about shifting our focus towards preventative care. And I was on a call yesterday with a surgery that mentioned they were trying to focus on their QOF metrics and, really invite those patients in for their blood pressure readings. They didn't have any time. They could only apply one member of staff to that, because the other 3 members of staff were too busy managing the inbound demand. And that's just a metaphor for the context of the issue that we're having across the country, is we need to be able to free up our staff that are working within general practice to allow us to focus on preventative care. And I just wanted to flash this graphic back up here just before we dive into the model, because with our current model, we're not going to be able to move from sickness to prevention. And that's due to compounding demand, causing issues and delayed care. And again, the cycle goes on. So if we think back to the 10-year plan, it's absolutely spot on. That's the direction of travel. But how does that trickle down into our regions, our ICBs, our PCNs, and even our practices? And it all starts with improving access into general practice, or I should say primary care as a whole, because we know we need to work with local authorities and our community organisations as well. So the model, again, I've presented this time and time again. The easiest way to explain it, it's almost, if you remove the surgery assist solution from this graphic, you've essentially got the modern general practice model, okay? And lots of you will be running all of your patients' requests, so whether they come in by the phone, the website, or walk in, moving to a total triage model, and we move over to the third swim lane here. lots of us, whether reception teams or patients doing it themselves, are completing an online consultation form, which comes into our teams, which we then have to respond back to. So we're having to communicate back to the patient to signpost them elsewhere. Yes, 50, 55, 60% of them will belong within general practice. We'll book them in for their nurse appointment or an ANP or a GP, of course. But actually what we've seen is that 30 to 40% of that demand, we're actually spending time to communicate back to the patient. So we're sending SMS texts back to the patient to say, oh, there's a health and wellbeing coach at our PCN, please complete this form. Or you can do that on the NHS app. Here's a link to the NHS app. There's all sorts of different things we can do, or that we are doing, that aren't conducive to the 10-year plan going forward. So we're too busy kind of treading water, trying to manage that demand coming in, and then signposting it back out. And that's where this operational efficiency model has come in, because if we remove up to 40% of that demand, or let's put it very simply, that workload coming into your care navigators and your reception team, we remove 40% of that. You don't need to have 5 call handlers on the phones between 8 and 10 in the morning. What we can do is we can take those 5 call handlers, we can say, what would you like to do within the surgery? We can send them on training days because we've now got time, and then we can change their role. So we give them role rotation within the surgery. Because the demand's reduced by so much coming in, they can then focus on the preventative and proactive. So if we think back to the previous slide where we have lack of time to do the preventive and proactive because we're managing this inbound demand, if we can just stop that at the front door, just add a layer of protection to our surgery in the form of a product like Surgery Assist, which I'll get to in a moment, is an AI-enabled care navigator, trained in multiple ways, local to you as a surgery, but we'll get into that in a moment. If we add that layer of protection to general practice before it comes in, you're going to free up so much time within your surgery. And I've had 30 hours of meetings a week for the last 2 years talking about this and the direction of travel. Yes, we can implement these amazing digital products within general practice, but if we want to reduce or free up that capacity in general practice and better serve our patients by getting them direct to specialist services, we need an automated system at the front door that can navigate them and leverage the whole of the integrated care system, not just come into general practice. And I've spoken a lot about reducing workload on our practice teams. Think about the patient. So if you think about a patient, somebody's a carer, they've had an exhausting week, Friday, Saturday, Sunday evening, they need some support. They are trying, they want to put a request in, they go to their practice website, they're looking for support for carers, or they might call in. They can speak to Surgery Assist any time of day because it's 24/7 enabled, and they can ask the question, I'm a carer, finding it difficult, is there any support available for me? And we've locally trained your Surgery Assist digital assistant to respond to the patient and navigate them or signpost them automatically at 8 p.m. on a Sunday, for example. What we haven't done is signposted them to our website to click the big banner at the top for our online consultation tool, for then that patient to wait 2-3 days to get a response from our care navigator, which not only costs the practice time and money because the care navigator has to respond to that patient, they have to send an SMS fragment, but actually that patient has had to wait 3 days for a referral into that service. And if you multiply that by all of the different services that you're signposting out to, potentially 12 of those at the PCN, you might have 80 in your local community. If we can pre-train your digital assistant at the front door, which is available 24/7, which has time-based criteria routing within it to effectively navigate patients to the right place at the right time of day. By that, I mean, if it's in hours, then let's send them through to your clinical assessment tool, which might be Patches or AccuRx, or Anima, eConsult, or the like. If it's out of hours, rather than them clicking that banner on your website and them not getting the ability to submit a clinical request because it's out of hours, what your digital assistant will do is recognize that the practice is not open, recognize that your online consultation tool isn't available for clinical assessments, so it can navigate them away. We can preload it with obviously 111 signposting, an out of hours service. You may have an enhanced access hub locally to you. We just want to empower the patient to self-serve 24/7. And the biggest part of it, and I don't have time to demo it today, but it's available in multiple languages as well. So the whole idea of this is to automatically navigate patients around the system to free up the workload on that. And I'll pause there, Lucy.
Yeah, could you, Max? Just because there's a couple of things that have cropped up. So one, this is a model that I think the Tony Blair Institute was encouraging last week in a report, weren't they, about the idea that everybody in the country, every practice in the country, should have a care navigation system on the front of their access.
Yes, yeah, absolutely. Yeah. I mean, yeah. Sorry, was there a question? Follow up?
There is. Sorry, that was a very long-winded way of getting to Jane's question, actually, because she's asking if ICBs are on board with it, and I'm sort of coming at it from this is a national kind of campaign, really, isn't it? Supported by organisations and institutions like the Tony Blair Institute.
Yeah, absolutely. That's a great question. So I answered this question a lot about ICBs. So I would love to know which ICB you're from. It's probably a good question, and I wouldn't be able to tell you off the top of my head, but absolutely we're having conversations with multiple ICBs up and down the country. We know that there's sometimes some local nuance, but we're doing lots of work with the ICB strategies and trying to help, there is this common goal from NHS England, or at least the government that's come out, and this is our 10-year plan to deliver, and how that trickles down into ICBs. Again, I mentioned patient demographics and variability around the patients that we need to serve. What I'm getting at is that some ICBs may have more of a focus on health inequalities, reducing the health inequalities gap. Some may have highly deprived areas, so they're trying to focus on the non-registered or the unregistered population in their region. What we want to do is speak to ICBs and ensure that this model supports where they're trying to go in their strategy. And again, not to give too much of a vague or broad answer, but on the whole, every ICB we've spoken to and discussed this with is very much in support of this model, because it's absolutely the direction of travel, as you said, as alluded to in the Tony Blair Institute report. And I will also say that it's really important to us. I mentioned local nuance there as well about different patient demographics, different local health strategies. Every single digital assistant we build and provide is trained locally right down to practice level, because we know in your PCN of 3 surgeries, a patient may need to book a nurse appointment, book an appointment with a nurse to get a blood pressure check. Another practice may have a nice new shiny blood pressure check machine in the waiting room that they need to signpost patients to. So it's really important that your digital assistant is built locally to you, and we believe that's not something that's being done by any other healthcare provider or health technology provider. Sorry.
And beautifully linked here, another question from Jason around: is Surgery Assist a registered medical device if it's diverting patients to pharmacy first, etc., without human input? Because they have been discouraged by the ICB with some similar, more simple care navigation tools in practice due to that.
Yeah, it's a really interesting question. It's a good question. We're not a medical device. We don't do any clinical triage. The pharmacy first protocol lists out the symptoms that you can self-refer for as a patient, and we surface those. We do, again, it's not a blanket fix for us. We do work with GPs, clinical directors of our procurement partners, and work with them to make sure it's safe, but we're absolutely following national guidance on that. Our clinical safety officers, we work with Curistica, led by Dr. Keith Grimes and Dr. Yusuf Akrochi. Yusuf Akrochi is on the NICE accreditation, on the NICE board of accreditation, and we've worked with him on developing this solution, and it's will be clinically signed off and safe. So any governance and compliance questions, we can point in the right direction to view that documentation as well. But absolutely, we want to make sure that we're doing everything we can that's safe. And on that note, we have got national partnerships with organisations like Drink Aware, so patients can come in, ask the question in any language that they'd like, that they want to know how many units are safe for them to drink, or advised or recommended alcohol limits and intakes per week. And we've got unit calculators that we've worked with Drink Aware on developing and implementing. They can mention they're concerned about friends drinking and get the right support that they need. No matter the time of day or language they need that support in. So just again, all of our pathways are built locally with the practice.
On that, Max, I think we're conscious of time. It'd be really good to see what you're talking about.
Yeah, good point. So what we're looking to achieve is a channel shift in demand, but not just a channel shift in demand that results in your capacity being utilised. So in October 2023, we launched at Southmead Surgery in Buckinghamshire. You'll see here that dark blue is telephone, green is Surgery Assist, so automated responses, and not just automated responses, but automated support for patients. So if I jump through to my trusty demo. Again, just want to show this and how if I call my surgery. So we've changed the IVR messaging. So patient clicks 1 for appointments. We can offer them digital support themselves. So if a patient clicks number 2 to receive support, we can send an automated SMS to the patient and introduce that patient to Laurie, which is one of our digital assistants. And I click that link as a patient, and what that'll do is launch Laurie, who's programmed with AI. And if, of course, we do our red flagging, in the top corner, we've got web accessibility widgets built in, so I can increase the text for visual impairments. We can go high contrast for any cognitive or visual impairments. But once we proceed past the red flagging, again, it's all being built with clinical safety and patient expectation in mind. The priority for us is the patient understands the journey that they're on and where they're going. And of course, the other job is that Laurie understands where the patient needs to go. So we monitor it. We tell the patients it's not monitored by practice staff directly. I'm not here to make clinical decisions, but to support you with accessing various verified health and care information. And then we've got a list of options that are customized to you as a surgery. We can include any sort of seasonal agendas, flu jabs, women's health. You may want young people's mental health. Anything that you want to surface at the front, we can have on these menu options. And I'm not going to have time to show you our NHS App pathways, but these have been curated and built over the last, let's say, 2 years. So this product has been in the market for 2 years, now part of the Gattlin Health family. But the NHS App guidance and support that is helping patients to solve, we've got verbal guides, written guides, video guides that can help patients navigate through. But conscious of time, I'm just going to click ask a question. If anybody wants to follow up, I'm sure Lucy can pop a form, or you can visit our website to submit a request, and we can book our own 60 minutes to go through this process. But in this example, I'm just going to show you how the AI is leveraged. One of our biggest, not biggest challenges, but our biggest concerns, and what we want to do is allay any fears of patients using the AI. So we do surface a guide that we've written ourselves, and the patient can, if they want to learn more, I can view this guide here. So what is an AI digital assistant? How does it work? It can talk in your language. We use Microsoft translation services. We talk about auto redaction of PII, so none of that is stored. And again, there's so many different kind of sub sections of AI and how it's utilized. So we want the patient to understand exactly what's happening here. If I'm happy to do so as a patient, I can proceed. And I'm just going to give 2 very quick examples here. So I'm now speaking to AI that's been trained locally. Again, the patient is reminded, I'm not here to make clinical decisions. So I could just put something very simple, like I have knee pain.
It's like, you know me inside out, Max.
and you can see there that we can surface NHS advice and guidance, or we can surf a self-referral form into a local physiotherapy service. Again, just in the concept of time, I need housing support. So again, I'm just trying to showcase how if we train Laurie up front, we can help patients 24/7 to access local services. And again, I really do want to open up for questions. I'm sorry, but I'm going to have to stop there with the live demo. But again, more than happy to do a one-to-one demo with you and your general practice teams. At the bottom, we've got options to basically exit the AI. So if I click contact the surgery, we've got a contact the surgery tile that will come up, and the patient can then either telephone. I will say that if you are a Surgery Connect customer, the integration is very powerful. They can actually join the callback queue from the chatbot rather than having to call the surgery back. The patient journey is everything to us. We've done a lot of work on making sure the patient doesn't feel like they're in a never-ending loop. So we've come up with this ethos of closed loop transactions that a patient is never in a cycle of kind of chasing their own tails in the panic and the stress they're under with their healthcare need.
Right.
Okay,
I'm going to stop you there, Max, because there really is quite a few questions popping up in the chat. If we don't get them covered today, we will send out an email after this with everything sort of summarised, and I'll cover these questions. In fact, let's just do that because they are flying in. So I think the last thing for me is just to wrap up. Thank you ever so much for your participation today and for the presentation, Max. I think this is there's a lot of interest at the end of this list of chats. I have just said to people, if they want a full demo, please put your ADS code into the chat and we'll get to you. But I think that is it from us today. Conscious of time, we hope you've enjoyed it. Thank you all for your participation. Our next webinar is planned for the 23rd of April. So I'm just going to pop the link in the chat there as well, in case you want to register early. If you'd like any further information on anything that we've chatted about today, or any pressing questions that you've got that we haven't covered, pop the ADS code in the chat and your primary point of contact will reach out to you directly. We'll make the recording available to all registered attendees in the next couple of days with all the relevant links. We hope to see you all back again next month for more. But in the meantime, on behalf of everybody at X1 Health, have a happy and healthy March, and we'll see you in April for more. Max, thank you ever so much once again. Brilliant presentation, and very excited to see what comes next.
Thanks, everybody. Bye-bye.
Bye-bye.